the relationship between mum and baby.
If you are in a fight or flight a lot of the time and you're anxious and those kind of things, that anxiousness and anxiety can follow on to the next generations and create other issues with them.
Welcome to the Brain Development Podcast, and we're here to show parents there is a pathway to healing the behavioural and learning symptoms of their neurodiverse child. And my purpose is to help empower parents to understand how they can build their child's brain from the bottom up to invoke change. And I have a very special guest today. We're joined by Dr. Steve Williams. He's one of the UK's most respected figures in chiropractic paediatrics. With over 30 years of clinical experience, Steve's dedicated his career to helping babies and children thrive. And he's an internationally recognised lecturer, former vice president of the British Chiropractic Association, and founding board member of the College of Chiropractic's Faculty of Pediatrics, and author of an acclaimed book, Pregnancy and Pediatrics, a Chiropractic Approach. And he continues to lead a busy family practice in Southampton, specialising in paediatrics and craniopathy. And Steve, it's an absolute pleasure to have you with us today, and I'm very delighted to have you on the podcast.
Laura, I'm delighted to be here, and thank you. It's a lovely introduction. I have to say, it's nearer 40 years now. I'm next year will be my 40th year in practice, so that's terrifying. But anyway,
well, time flies when you're having impact. So I'd love to understand, over those nearly 40 years, you've been helping so many babies and children. What really drew you to pediatric chiropractic from the first instance?
What drew me was having a child born who was had a dysfunctional birth, as so many do, and he had he was one of the most difficult babies I've ever seen. And, I'd started seeing one or two, but I had no particular expertise in pediatrics. And then he turned in from a nightmare baby, vomiting repetitively, not sleeping, not doing a whole range of things, into a child who was very slow learning, slow meeting all his milestones, and the slow being all kinds of stuff. He had a severe astigmatism, bottle-top glasses from 18 months, and was just a really, really slow, dysfunctional child. And I just thought, he can't be like this. We've got to find a way to do it. So basically, I started looking around the world. I looked at all the people doing work in the areas of being slightly alternative in this, and I traveled and I learned, and I ended up helping him a lot. So much so that when he's a chartered accountant working, he's a CFO of a big company now, and he did say to me, "Dad, your career is based on from what you learned from me and going on from that." And I said, "Yeah." He said, "And your book and all those your seminars you do?" I said, "Yeah." So I said, "Don't you think I should have a percentage of your earnings?" And I thought, "Yeah, no." If I should have a percentage of yours, because you wouldn't have done it without. But anyway. So that's how I got into it. And then I started into the classic thing of seeing babies with symptoms, babies with all kinds of issues. And then it went from there on to really working with more complex cases. The more expertise I developed, and I put together a master's degree in pediatrics with a colleague for the Anglo-European College of Chiropractic. We started qualifying people in chiropractic pediatrics, and I worked a lot in those kind of things. But the last 10 years have been a real total change of focus for me, because I've been working much more with neurodiverse children, much more the autistic spectrum, the ADHD children, because we're seeing so many more dysfunctional children than we did. Now, that might be because my expertise has changed, and people self-select, and they do that. But I don't think there's any doubt that although the diagnosis for autism and ADHD and all the other issues is much more available, but there are more neurodiverse and particularly severely neurodiverse children that we're seeing these days than we ever did previously. And that's one of the costs of some of the issues in modern society.
Yeah. I mean, that's my next question. You've obviously seen it before, and now you're seeing it after, and we've had some major events. So how different is it now over the past 10 years to help to kind of enable where we are with our children?
It's very different. I think the past 10 years have, we've seen a massive increase in neurodiversity, and what the biggest increase we've seen in issues with children was undoubtedly when we had the issues with COVID and the lockdown. The lockdowns were a nightmare for all of us, and for children in particular, because they needed exposure to others. They needed exposure to people, and not and having people with masks on their faces and stuff was just crazy. And so many children who would have been far more functional became far worse because of those kind of things, I think. But I think the reasons behind it are, there's a multitude of reasons, including modern diet, including, the chemicals involved in society these days, the poor nutrition, but also the way the birth process is involved in, we've seen so many more cesarean sections. And I can't emphasize the importance of a baby going down the birth canal. That's right, I don't have to do it. So it's one of those things that it's easy for you to say, yeah, it is. Okay, but if you can avoid a C-section, and C-sections are magnificent, they are life-saving in the right situation, and they are really appropriate. But we need to avoid it if we possibly can. Going down the birth canal stimulates so many of the primitive reflexes, fires up the primitive reflexes. And those primitive reflexes, the reflexes which a baby has to develop in its environment, to fire up his brain, to start activating those systems and to survive in its early world. And then, also the microbiome, that microbiome of the mum's urogenital tract gets fed in the weeks prior to delivery with lots of good microbes, which the baby then gets covered in as it goes through the birth process. And that and the compression and the squeezing to activate the reflexes and activate the cranium and get that moving are massively important for the development of that child. And we see lots of other issues when the children don't get that sort of development.
I mean, I see lots of parents that have had elected cesareans or emergency cesareans, and either way, coming out as a cesarean baby, you don't engage those reflexes, you don't engage that sensory system at that point in time, so that you're at a disadvantage already. And then you might not be able, might not latch on. There might be tone issues. Like I listened to a lecture, and you just blew me away in terms of the piecing it all together, because I've done pieces with my own son, and over this journey, I put it all together from beginning to end. And also all the practitioners that in the UK that can help families with different things that aren't functioning, whether it's, tone and tonality or myofascial issues or orthodontics and biological kind of intervention around jaw and airway. And that's what babies are coming out to do. They're basically here to feed and survive. So if they can't do that, first of all, what happens after that?
Well, that's the point of the primitive reflexes. They are there to do that. And so when a baby comes out and can't feed properly, can't suck properly, it's your first indication that you've got an issue with some of those early reflexes. Now, it might be a tongue tie, it might be those kind of things, because we do see some tightening some of the midline structures with some of the ways we're preparing for birth. But often it's not necessarily just that. It is the fact that baby has got issues related to the ability to move the tongue, because the primitive reflexes, for example, the rooting reflexes, aren't brought up to threshold. If they're not up at threshold, the baby will then most likely have a poorer suck, won't be able to latch as well as it can, won't necessarily latch on and draw the nipple to the back of the mouth, all the things it should be doing to create a really effective suck.
Yeah. And then, thereafter, there could be further issues that you might not even pick up on. So, I've seen, and I work with a naturopathic nutritionist, but when you look at a lot of the children that we both see, there are, cradle cap and colic and these types of signs throughout those first few months that I never put together, and I experienced all of it. So are there other things that parents could be looking for or just be more aware of if they're going to have other children?
The biggest thing is really is the initial stuff. If your baby can feed really well and can feed well off both breasts, doesn't have a positional preference, and our positional preference is, does it keep its head rotated to one side all the time? If it's got a positional preference, that's going to potentially lead to some issues. All very treatable, guys. Don't be afraid of it. I'm not trying to panic anybody. If you can get them to myself or colleagues, who can do this kind of work, it's not a problem. It really isn't. But if they have any of those kind of things, and if they can't poo, they should be able to also poo. You want a baby that can take stuff in, can process it, and then get it out. And if it's starting to gain weight, it can feed well. It can feed off both breasts equally. It doesn't have positional preference and it's pooing well. Worry be. That's a great start. That is a great start. And that's where you want to be. If it's outside those kind of things, then we've got issues. Now, they don't necessarily lead to neurodiversity, but they are going to affect the baby's early development.
And that preference, either one side or the other, that's because of tone or lack of tone one side, and they can only feed on, a particular side. Is that right?
Well, tone is an interesting one. What I'd phrase it as is, we usually see those babies who have a positional preference when they've been either stuck in a wonky area in utero where they've got their head stuck up in a corner or down, or they've been engaged for a very long time and the head is rotated and twisted, or they've had a delivery which has been less than ideal. If they've had a forceps of on twos, they were stuck in the birth canal for a long period of time, all of those kind of things, or a cesarean section, whatever. They've usually had an issue which has created that torque. And it's often a very straightforward mechanical skull-based torque where the upper two vertebrae are slightly twisted and they've been locked in that twist often for a little while, particularly if they're in a funky position in utero. And then the vagus nerve, which comes out the base of the skull, just above where the first cervical sits, is being inhibited, and that'll often create issues with the gut. And because there's a little muscle which goes from the first cervical vertebra and surrounds the jugular foramen where that vagus nerve is, the rectus capitis lateralis. Makes you sound important if you know these names in Latin or whatever. It can also create an alteration in the vagal firing and vagal tone. And that can also, because the muscles, where the other nerves coming out of there are the nerves supplied to your sternocleidomastoid and your upper trapezius muscles, which can create the rotation, or they're also the nerves supplied to the muscles of swallowing. So they can often affect swallowing and lead to babies choking easily or having a loose larynx and stuff like that. So all of that comes out of that tiny little area right at the base of the skull. And that's a whole range of symptoms that can occur from that and go along with positional preference or without it. You can also get crowding in that area without a head positional preference. But positional preference is a thing we see a lot of. And that's the beginning of also the asymmetry, the plagiocephaly, the asymmetry of the head. Because if you rotate it to one side, you're going to tend to flatten the place you're lying on. And that will tend to go flatter and flatter and flatter and create a whole head becoming asymmetric. And then they don't like turning to the left. And that can lead to alterations in tone because you've got the firing from your upper neck, the joints in your upper neck, they're called proprioceptors. They fire and they go into your cerebellum, which is that little area at the back of your brain. And that needs equal firing to then develop the rest of the brain. because the front of your brain, your frontal and your prefrontal cortex, grows out of activity coming through, and we want equal activity, so we get equal growth of that prefrontal cortex, which is your executive decision making, your functional area, which babies don't have, but they grow it, and it comes out of those areas. But making sure the firing into those areas is equal is massively important.
I mean, that's what ends up having a child that is very, very, exceptional one side and just not the other, and the immaturity's there. So I've also seen a little girl who isn't walking yet, and she was born with a lazy larynx. So you mentioned that just now. I'd love you to just tell me a bit more about that and why. Is it because she may have been, maybe twisted, or what would cause that?
So one of the things, there are multiple factorial things with this, and there can be other causes. And I'm not, going to claim this is the cause of all lazy larynxes or anything like that. But one of the things we see is when the vagus and the glossopharyngeal nerves, which are responsible for this laryngeal area and the tone in that area, when they are dysfunctional, if that area is being affected, the skull base can affect the larynx. And by opening up and trying to normalize the tone around the base of the skull, which is done with very, very gentle techniques, and that nothing can get unpleasant or vigorous on babies ever. And the very gentle techniques allow the firing of those nerves to normalize. And then that's what we wanted to try and affect the tone of those other areas, which it often does. And we see, I get lots of babies being brought in with very noisy breathing and things and loose, like they call it a loose larynx or a loose, a floppy larynx, is a common description. Part of that can be related to these issues. It isn't the only cause that I want to emphasize, but it is one of them.
And when you mentioned a number of things there in terms of, the vagus nerve and all of the nerves in the brainstem. In terms of like the development of that nervous system, could you talk to me a bit about that? And
So the primitive reflexes, which are brainstem orientated, they come from the brainstem, and they're the things which keep us. So let me give you an idea of what the primitive reflex is. Your baby's hand, you go in, you stimulate it, the baby will grasp over. And you see often babies like this, or they're like this, they've got really tight grasps. That's a grasp reflex. They have a plantar grasp reflex on their foot in a similar way. So it's really like the apes being able to hang on to the trees with their feet and stuff like that. So we've got palmar grasp, we've got plantar grasp, we've got rooting reflex to let us find the nipple. So the rooting reflex is for the baby to be able to get onto the nipple and be able to feed itself. We've got the Moro reflex, which is that abduction, adduction thing, which is, I basically call it the hairy mother reflex, is to hold on to our hairy mothers to be taken away from danger. Now, as a baby, we're not capable of that, but our ape ancestors are, and we have those reflexes there. And there are a number of other ones. Yeah, there's one of them, the biggest one, is the tonic labyrinthine reflex. So if you think about a baby, they're born with flexor tone. Their tone is forward. So they're all flexed up. That's to make the smallest area so the baby's scrunched down into the smallest area in the mum's tummy so that it takes up less room. Now, the tonic labyrinthine reflex backwards, so that's forward. You flex the baby's head, bend it forward, the baby will scrunch up. Also, if you extend a baby's head beyond level like that, the baby will extend out, will lengthen. And that is, when we see that, when a baby's head crowns, goes through the birth canal, and then the head comes into extension, that causes the baby to straighten its body out and to go and push its way out the birth canal. It's a beautiful design. They're helping the delivery of the baby. And these are all brainstem orientated reflexes, which are meant to be inhibited, or more accurately, integrated in the first 3 to 9 months of life. Okay, and there are others. I won't go through them all, but they can help in the birth process, and they're also there to keep the baby alive in its first 3 to 6 months. And then their importance diminishes And the reflexes should be inhibited by what we call the neck righting reflexes and the body righting reflexes. So these are reflexes which keep us up and level. Okay. And when those reflexes aren't stimulated up to a full threshold, so when those primitive reflexes don't get really activated, they often don't get inhibited. And that can create lots of issues later on with learning, because there's a fuzz in the brainstem. They're firing off all the time in the brainstem, and they create a mush in the brain, which make it very difficult for a child to concentrate or to learn or to do any of those things. If that reflex is there, they create a difficulty for that child in learning, and they're so important that they are reduced down. We score them out of 4, and we want them on noughts or ones. We want them very, very low, so that those reflexes are no longer an issue. And they're in various areas of the brainstem. And basically, when we start developing our frontal cortex here and prefrontal cortex, there is an inhibition that comes from here back down to those reflexes, because you shouldn't ever have those reflexes come back in life, except if you have something like a major head trauma, if you have a frontal bleed, a stroke, or a tumor. You see people, when they've had a stroke, their grasp reflexes are back. They're in those. And that's when this frontal, the frontal inhibition releases. It's called frontal release. And that is, but it shouldn't come anyway. So it allows, as these reflexes decrease, it allows the development of this frontal cortex. And the more this develops, the more it inhibits the reflexes. So it's a front to back sort of inhibition of those areas. And when those reflexes are integrated, is a better way than inhibited, because that's actually what happens. They become integrated into the system. Then you get an equal development of the individual. Both sides of the brain are able to develop and work so much better.
And you also, you mentioned on that lecture I listened to about the relationship between mum and baby, and how sometimes mum has, certain things going on, or may have a heightened Moreau, or may not have had that integrated herself. And treating the parents sometimes is also a way to help the child.
Well, it's a very interesting thing. We know the research is really quite strong in showing that mums who have had adverse childhood experiences, and this goes down generations. We know in the research is back to 2 or 3 generations back, that adverse childhood experiences which have created issues for the parent, and we all know these, and these are not said to make parents feel guilty or anything else about what they passed on. This is just the way the research is. But if you have those things, and if you are in a fight or flight a lot of the time, and you're anxious and those kind of things, that anxiousness and anxiety can follow on to the next generations and create other issues with them. So it's one of the things that mums also have I know the umbilical cord's been cut, but they're connected to the kids. There is a much great, and dads are connected as well, but nothing like that connection that mums have. They've got that silver umbilical cord still going to that child, and they often feel the things. You ask mums, they'll wake up before the child wakes up. They know they're about to wake up. They know something's gone on. They know the child's not happy. All those connections, how'd they know? Well, yeah, they are connected. There is something in the ether which is connecting them. And so mums trying to make the best, and mums are the worst at getting anything done themselves. They're always on it's got to be the child. It's got to be the child. Yeah. And that's a human survival thing. They would stand in front of a bullet for their child. They would do that without thinking. And that's great. Okay. But it doesn't mean that they shouldn't get themselves sorted out, because a lot of the time that will help the child more than anything. If the mum can come into good regulation of her system, that can really, really help the child. That as well. But, mums are certainly for the younger children are a very strong influence.
I mean, mums know. They come to me and they say, I just know that there was something, but I couldn't quite put my finger on it. So there is a real intuition there with all mums.
There is.
Yeah.
There is. And we see that all the time. Mums are so aware of it. And to be honest, most of the time, because I question people, when did you first notice the issue with your child? And it's easier for those mums who have had babies before, because you can see in the early development. But a lot of the mums will say, well, I just felt it was 6 or 9 months and I just felt there was something not right. And the evidence is actually that you can recognize it in most, not all, because there are some late onset, but in most children, most babies, there are certain developmental things that we look for which need to be, and those are often around reflexes and a range of other things, which need to be inhibited, and the child needs to be showing certain behaviors for us to know. And I don't know if it's probably not useful for me going through those, because it's going to make a lot of people very nervous about.
I think you should go through them.
Okay, so one of the biggest things is eye contact. Babies should have good eye contact. They should want to listen to you. They should want to watch your face. And parents need to be getting into their baby's face and talking to them with expression and with joy and frown, show them all of the facial expressions. And the baby should be looking between your eyes and your mouth. Okay, it's looking at your eyes, because the eyes are the first thing, the mirrors to the soul or whatever. And then they should also be watching your mouth, because that's where the noise is coming out of, and that's what the baby wants to be doing. So in the first 3 to 6 months, we're looking for really strong eye contact. And babies who won't make eye contact, we need to start looking at things like that they're doing. And also the things called protophones, the noises babies make. They should be having a higher proportion of lovely sing-song protophones. All babies scream and cry and make nasty noises from time to time, but repetitive early, or repetitive, nasty, irritating noises, okay, should make up a very small percentage of what they do. And the protophones should make up a much larger percentage. So they should be making more joyous, noises. It's really that noises of early speech where they're copying the tones and listening to those different tones. And it's as if they're starting to speak. If they're doing that, they're great eye contact and they're making lots of those lovely sing-song noises, glory be. And some of those da, 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 those repetitive noises as well are good. Where they start repeating da, da, those kind of things. We're looking for. But outside those, if they're not doing it, then that's when we would start wanting to look at what's happening in that child.
And movement's obviously exceptionally important because it builds the brain.
Yeah, movement is very important. And I'm going to be really honest. We're very strict on looking at those milestones. They need to be making their milestones at appropriate times. We want them, drawing their legs up. We want them lying on their tummy, start lifting up their head. Tummy time, right, guys? Please do tummy time. It is so important. And I see so many times people come in, they didn't like tummy time. I don't care whether they like it. They're going to do it. Lying on you, getting flat lying on you. That's tummy time. Yeah. Oh, I've never known a baby lying on its tummy on its mum, which doesn't like tummy time. They like it. You can start off if they had a nice, easy birth, start off from day 1, or day 2. Start them on tummy time, just on them for a minute or 2, and gradually increase it. Tummy time is really, really important. It's been shown to be linked to all kinds of development. So they will then, that's when they start developing extensor tone. They start being able to lift their head up. Now, don't expect them to straight away. But just being on their tummy, and they're pressing on areas that are really important to the development of that baby. They need to do tummy time. You can do that on you. You can put your hand underneath their tummy and fly them around the place. It's not quite as good as them lying down, but it's great. Developing that extensor tone is the first kind of thing, and that's the first thing that develops over the first literally in the first few weeks of life. They start firing up their extensor tone. And so they start coming out of this forward thing. They start getting some neck stability. So the deep cervical flexors and the extensors start firing up and start balancing up their neck tone. And one of the tests we use is what we call a head lag test, where we're looking to see, is that baby capable of stabilizing its neck or not? So we want that developing in the first 6 weeks. Okay, where they're starting to develop some degree. It's not perfect by any means, but some degree of tone. From there, from then on, we're looking at what age does rolling occur? What age can they flex their legs up? They bring their hips up. So the first way a baby rolls is usually from its back to its front. And it's usually done accidentally. They're bringing their legs up as they bring their knees up further than their hips. And they're coming up. They'll often go to one side and they'll end up on their side. That's the first time they roll on their side. And it's great. And it often shocks them. And they go, what's happened? But then they need to do that to both sides. Then later on, in a month or two after that, they'll start rolling from their front to their back. And once they can roll from their front to the back, they're happy on their front. But they need to have done quite a bit of time to do that. And then we're looking at things like can they sit up lovely and straight? We want a lovely straight back. 5 to 6 months, we want that back. They're not stable, but they're as long as they're straight and they're doing. Then they develop stability. 6 to 7 months, they should be sitting stable, able to reach, able to do things. And then we're looking at doing a hand lean on one hand and reach for something with the other. And then all of those things. And then we go into that's the beginning of actually surprisingly how they learn to crawl, because they learn to get in the crawl position from a side pivot stand with one hand, and then they roll round into the crawl, and then they start developing the crawl for there. So all of those kind of things should be occurring in the first 7 months of life, 7 to 8, and we're quite strict on those kind of things. So what we do is once we've seen a young baby, and once we've cleared up whatever symptoms, it's often symptoms they're brought in with, then we're sort of saying, okay, I need to see them this date, this date, this date. And I'm telling the mums what I expect to see. And I'm also telling them things to do to encourage that, because we can give exercises for all of these things. And by the way, those mums who've had a C-section delivery, there's some great stuff that they can do to activate. If you're worried about you having a C-section and what effect that's going to have on the baby, we do I send them people videos of a strip massage we do 2 weeks after the delivery. We recommend that mums do this, and that fires up those reflexes to bring them up to threshold. And if they can work on that and work on their microbiome, give the baby probiotics, mum takes probiotics, although particularly breastfeeding and feeding that, you can minimize the effects that a C-section causes. So the long-term outcomes can be better. And that's what we're after. We're trying to make really positive changes to these guys.
Yeah, I've seen that massage and, on my journey, as well as what to do about the whole microbiome side. But I didn't realize that that's you advise that and you're practicing it.
I've sort of developed the one we do. It was one I developed over the past sort of 30 years. And if anybody wants it, if they email steve@stjameschiro.co.uk, I'm very happy to share it.
That's very kind. And, a few last questions. So if you could, you're obviously doing a huge job in helping so many families and changing the trajectory of some of these children. And I know that you talked about when if you could get into every hospital and see every child, that you would right from the beginning and do some adjustments on that child. It can help so many. But if there was one thing in healthcare around children that you would love to see in your lifetime, what would that be?
Well, that's a great question, and I'm not sure I could bring it down to just one thing, because there are so many things that I think we need to change the diet. We need to get rid of this thing that, why do we feed babies sweet things? I'd like to change the education of the parents. We need to go back to feeding people like they did before the Second World War, that we actually have meat and vegetables and all those kind of things. Or if you want to be a vegetarian, we have other things. We eat the vegetables. We don't have the ultra processed foods. That's what I would like to remove more than anything. We don't have the sweet stuff. I always tell mums, don't give your baby anything sweet. in its initial thing. Not even really sweet bananas, mushy bananas, because you sensitize them to sweet. There's no human being that ever needs to be sensitized to sweet. We all love sweet things, even if we deny we do secretly. And but babies need to be able to get used to other tastes, like bitter, like sour, like all of the salt, or all those kind of things, to actually bring their system into enjoying lots of different flavors and textures. And textures are massively important as well. I'd also say textural stuff. We see so many kids with massive textural issues. I'm not a believer in giving a child, pureed food. What do we puree food for? When in human history could they ever puree anything? They've never been able to. So, my baby might choke. Look, if you just break it up, mash it up, with a bit of a pestle and mortar or something like that, mash it up, leave some texture in it. Okay. And if your baby does start choking, chuck it out. It won't go in. Texture is really important. They need to get used to those things. So for me, it would be a change in the way we educate parents to look after their children. That's what the NHS, it's a great sickness service, but it's not promoting health in what it's doing at the moment in lots of ways. And we need to start promoting, this is the way to make our children healthy. They need to be active. They need to be physically active all the time, not on electronic influence machines, all that kind of stuff. They need to be doing things, and they need to be eating properly and drinking properly and getting good stuff in there, rather than going to McDonald's 3 times a week or having pizza every night and all those kind of things. Because I know that's all a lot of the children I see eat. They will only eat pizza and chicken nuggets, and that's it. Okay, well, that's not going to, no one's going to be healthy on that. We've got to change that progressively. And if you don't do it in the first place, don't give them the opportunity to have it, it's quite difficult for them to develop that. Okay, yeah. And that's the truth. So parents need to be, I'm going to be strict with my child until it goes to its first party. And then we've got no choice about what they have. But just the other thing is, if I could have 5 treatments or trained people, and with my trained colleagues who've done this work, have 5 treatments on babies when they're young, I think we'd see a lot less issues coming in. Okay, if they could see someone who's experienced in musculoskeletal stuff, because so many babies have significant MSK issues which develop into neurological issues. Because most of the time, if we're talking about positional preference, is an MSK issue. But if it doesn't self-correct, and some of them do, but a lot don't, they'll develop into a neurological issue because they will have reflex retention, they'll have asymmetrical development in the brain, and all those kind of things. And that's so important to get sorted early on. And educating GPs and lots of other of the normal healthcare or the standard healthcare in the what to look for, okay, and why they should be looking for those things, and that this can create long-term issues, would also be a passion of mine to get involved with. There'd be lots of things I'd like to do.
Well, you're doing it. You're helping parents now and families in changing those trajectories. So I think there's so much in there. Like with regards to food in our society, it's just become so convenience food that is what parents end up. They've done it themselves. It's what they want, and so then they then give their children that convenience food. But when you look at supermarkets and how it's changed so much, even over the past 10 years, if we're just going 10 years back, I mean, the majority of the supermarket is all processed and it's all packet foods. It's just you got to stay in the meat aisle and or actually go to the butcher's and find a good place to go and source your meat, but then stay in the vegetable aisle, and that's it. Don't go anywhere else in the supermarket, because there is just so much in terms of bad food that it becomes the norm. And I did a podcast this morning on when did it become the norm to feed your children Haribo and donuts after school. So it's just become the norm because it becomes a treat, but then a treat isn't a treat like you and I had when you'd have an ice cream like in the summer, and it would be a handful of times. It's like every week now.
But then also, I'd really regard it as a cruelty to the child. Feeding them, allowing them to have these multiple things like that on a really, look, if you have a one-off of a Haribo and a donut, well, who gives a stuff? That's not the issue. But if it's every day or every other day, it's getting to be too much, and their system then gets sensitized to it, and that's all they want. Their blood sugar becomes unstable, and they start craving sweet things, and then we're on a loss. And we've got to go back to eating real food. Okay. And a lot of people are scared of it because they've never learned to cook. There's been a generational thing that people have lost the ability to cook. And it's so easy and straightforward to cook. And it's way cheaper than buying the ultra processed stuff as well. You cook yourself, it's so much easier. And there's nothing wrong if you're going to have a treat once a week, go and have it. Go and have whatever you want. I'm not the Scrooge who's saying you can't have any of this anymore. But if you make 80 or preferably 90% of what you eat good food, not ultra processed, you will make big differences to yourself and your children. Your own well-being, your own happiness will be better if you're eating good food. You'll make brain neurochemistry better. Your brain chemistry will be better. Your blood sugar will be better. And the same for your child. And it's very interesting. One of my patients who we did some blood tests and found that he was reacted to folic acid. And so we put him on folinic acid, which is the new, like the big drug in the States for lots of autistic kids is leucovorin. It's basically folinic acid. So we have a source of folinic acid. We've gone on that. But also to do that, we've got to get him off all sugar and all dairy and all gluten and everything like that. And then the child has changed massively.
Already.
And part of the thing is, well, is that because the diet's changed? And or is it the folinic acid that they're on? And I'm going to say a significant part of it is probably the diet, but we'll see. So I mean, it's a lovely journey to be on with these children. It's so much fun, and it's absolutely my passion. And lots of people keep asking, when are you going to retire? I say, no chance. Why would I retire? This is so much fun.
There's just such a difference that you can make to so many more. And there's very few people that in the UK that are doing that kind of job. There's more and more people are learning it, but we just need more and more practitioners to help on the mission, really. But I've really
that's absolutely right. And gaining the thing is that the expertise is largely in the US, and that's where I've learned lots of the stuff, and lectured with some of the guys from there, Rob Malilo, and and that's where we get all the equipment. All the lasers come from there we use, and all of the various other stuff is all US based. But they've had more of the ultra processed food, more of the cesarean section, more of lots of the reasons for longer than we have. Although we are the leading nation in Europe is chasing the standard American diet, and I think it's something we ought to be ashamed of, guys. The last thing we want is the kids eating the standard American diet.
Yeah, and the amount of children that are just getting diabetes and other illnesses early on in childhood is just we are following them. But there's a lot of work to be done, and I know that you've got lots more people to see over your career, and I'm helping as many as I possibly can too. So, last piece of advice before we wrap up. You've given lots and lots of pieces, but if there was, another thing that parents should be considering, what would that be?
Are we talking about parents of a child with neurodiversity? I think the biggest thing is that they need to look. It's not looking at one thing. There are so many things that are involved in it. Like we do gut testing, we do testing of brain neurochemistry, we use neural zoomers, gut zoomers, we do a whole range of things. You've got to look at this in a wider spectrum. And if you can find a relationship with a professional who can deal with lots of these things, and the things that they can't deal with, they're going to refer on to someone who they know can deal with it, because we all have our expertise and stuff like that. Then it's a really, really important thing. So I think the primary thing is find someone who you are comfortable working with and who can deal with a lot of these issues. And it's not, if you've got a neurodiverse child, you're looking at lifestyle, you're looking at primitive reflexes, you're looking at diet, you're looking at sleep, you're looking at a whole range of things. And then we're looking at so many things which can fire the brain neurochemistry. Like the tests we do, we see if they've got any of the herpes viruses affecting the brain. We look at strep A, we look at a whole range of other things, which can all be issues within those kind of things. So you need someone who's going to take a wide view and try and identify what the primary factors are for that child and then do it. We find lots of people are getting in touch because they know we use the lasers and they say, oh, we want laser. Okay, well, what have people had a look at? What have they done? What's been the thing? And, it is a question of, lasers are very useful. It's all very useful, but you need to target it into what is the primary things that you can get to help that child change. And that's it's individual medicine, which is what we should all be practicing progressively over the next 10 to 15 years. I think that's going to be the biggest development of working with individuals.
Absolutely. I believe exactly that because every child I see is different. Every program I write, every assessment is unique. And it is specific for them. No child I've seen is the same. And everything it needs to be very bespoke from gut to brain and the whole development trajectory. So Steve, I've loved this chat. I'm sure so many parents are going to really enjoy listening to this. So I appreciate your time. Thank you. And I'll leave you to get home now.
Well, it's been thank you for the work you're doing. It's so nice to make contacts and speak to people. And we met a long time ago, but so nice to make contacts with people who are working in this area because we need more. It's really exciting, and keep doing what you're doing.
Thank you so much.